Hi, it's so nice to see you both. I am always really happy to be in community, I must say, with Dayna and Mona, two of my real heroes in all aspects of life. And I really appreciated that Dayna volunteered to be my daughter's pediatrician if needed. She's on her way home, in case you all wanted the update. I know. She didn't want to go home, which apparently was why there were so many phone calls. And as a parent, I'm like, I'd love that you want to stay at school. But if the school nurses tell you you have to go home, you've lost that agency. Like, you then have to listen to the experts. And speaking about experts who are so focused on trying to protect kids and build resilience in kids and in communities, I really could not imagine two people that I would like to continue to learn with and learn from than Mona and Dayna. And so really, thank you both for being here so much. Mona, I wonder if we can start with you. You know, we were just talking about the need to build resilience and responsiveness, you know, at the local level. And you know, I think we heard quite compellingly from Lindsay, from Dr. Burkhardt, and from Dr. Benjamin and Mark, while there is so much that can happen, you know, at the individual pediatrician level, as you two know better than I do, there are kind of more levers that can be pulled at a public policy level and that require kind of multi-stakeholder, kind of population level engagement and decadal commitment. And so that was really just a prelude for you to be able to talk about what you're now up to in Flint.
Well, thank you for that opportunity. It's great to be here. It's great to be here with my environmental besties and my early childhood besties, and to be in the same space and to recognize the intersectionality of all of this work. Kids do not live in a bubble. They live as part of a family, as part of a community, as part of this global environment. And we have to have all of these partners together to be able to solve their intersectional issues. So pediatrician in Flint, helped uncover the water crisis and helped care for kids who didn't know where they were going to get their next glass of water. So part of climate change is going to be water scarcity issues. And with that comes the worry and the anxiety and the trauma, the PTSD, the guilt, all of which comes with any kind of environmental disaster, any kind of preventable environmental disaster. And I think that's part of the burden here. When kids are part of something that could have been prevented, there's another layer of trauma and anger. Like, why did that social contract get severed? Why weren't these grown-ups taking care of me when they should have taken care of me? So what I'm working on now in Flint is no longer an effort to build individual resilience, which we do a lot of. We wrap our kids with a lot of goodness in response to our environmental crisis. We do literacy programs and home visiting and trauma-informed care and mental health resources. We do a lot of asking almost victims to do more, like, all this bad stuff happened to you, sign up for this nurse home visit. And it makes me feel so guilty when I tell my patients to do all these other things. So we're taking a step back and we're working with lots of different partners and we're trying to build community resilience, trying to address some of the root cause issues, and at this really critical time that we all care about, this prenatal, infancy, early childhood time, we've launched something called RX Kids, Prescription Kids, where I am now going to have the ability to prescribe away poverty, which has been something that has been maddening as a pediatrician. I got lots of tools in my doctor's bag, but I can't prescribe away the ability to take away poverty, which we now know the science hurts developing children and as toxic ways as lead exposure. So we're doing a citywide maternal and infant allowance program. Every pregnant mom, every infant up to the age of 1 is going to get unconditional cash to disrupt poverty and improve child health equity. So this is awesome. RX Kids. FlintRxKids.com. We're looking for more funders, so come talk to me after. But people are like, why are you in this space? You're a pediatrician. Like, why do you care about environmental stuff? Why do you care about economic stuff? Why do you care about racial justice and all these different things? We have to be in this spaces. This is not just the role of pediatricians. This is all of our roles to come up with big, bold solutions. We can't keep doing the status quo. The status quo is not working for our children, and it's not going to work for their children. So we have to get out of the box and try big, bold, new things based on science for what is most important for our kids and their health.
Yeah. Dayna, speaking about science, you and your work have really been at the forefront of establishing the relationship between toxic stress and kind of its effects on child development, and then consequentially on kind of lifelong development, and kind of really kind of discerning and identifying, the biomarkers around kind of the stressful experiences, beginning in the womb for kind of childhood development and kind of lifelong realities for kids and the adults that they grow up to be. And I'm just, curious how you think about that work kind of tying into Dr. Burkhart's work around kind of the effects of climate change, on kids. How do you think about trying to, assess and quantify like climate change now as a stressor on kind of fetal and early childhood development? And I guess really what I'm asking you is, what should we know about your science today, and how does it relate to this conversation?
Say how great it is to see you. And Mona, you're like a hero to all of us, particularly all of us pediatricians.
Village of heroes.
So I am a professor of clinical medicine at UCSF, and I co-direct and founded our UCSF Center for Child and Community Health, where our entire mission is how do we be a positive force so that all children can flourish and live healthy, wonderful, happy, joyful, delightful lives. And we do that through a number of ways. So one is through clinical transformation, through systems thought leadership, and through research on health equity. I am the principal investigator on a tool that many of you have probably heard of. It's called the ACEs tool. So ACEs stand for Adverse Childhood Experiences. And historically, ACEs has been a tool that adults have used to retrospectively reflect on these early childhood stressors. We call them adversities. They're related to abuse, neglect, and household challenges. My research is really taking a prospective look at how adversity accumulates over time, certainly wanting to be true to the traditional science that showed that as adversity accumulates, there is something called allostatic load. The notion of allostatic load is that we all carry around these buckets in life, right? You hear this expression, there are drops in the bucket. But eventually these drops in the bucket add up, the bucket tips over and can lead to poor health outcomes. So we're looking at how adversity combined with a broader understanding beyond abuse, neglect, and household challenges, how these social drivers of food insecurity and housing instability, experiences of community violence and discrimination, how they are actually getting underneath our skin and influencing health outcomes, and how does resiliency and protective factors really keep your bucket uprighted. What we have been able to demonstrate in very young children, so these are 0 to 11-year-olds, the vast majority are about 5 years old, is that these experiences of adversity, even having one major traumatic event, really does get underneath children's skin. And we're seeing that even one adversity can cause worse physical health, including somatic complaints like asthma, like headaches or stomach aches, diagnoses such as asthma and obesity, but also behavioral and mental health concerns such as anxiety, such as depression, such as decreased executive functioning, which is really important for a school-age child in the classroom, and that there's a disproportionate burden of these adversities on children of color and low-income children. Interestingly, this is embargoed information that I'm really excited to share. We just submitted an article for publication that looked at the correlation between adversity matching that with ambient air pollution, and then looking at biomarkers, as Chelsea suggested. And the particular biomarker that we were looking at, and Mona, you can help me out, this particular biomarker called telomeres. And so telomeres are DNA protein structures that are on the ends of our chromosome. It is a natural process as we age for our telomeres to shrink. And shorter telomeres are associated with aging. They're also associated with chronic diseases such as cardiovascular disease, diabetes, and cancer. What our research demonstrated is that children that experience higher levels of adversity, which are often low-income children of color, who also are exposed to higher levels of pollution, have accelerated aging of their telomeres by the age of 5 years old. This is tragedy, right? This is like the science that needs to get shouted from buildings, is that adversity plus poverty plus climate change is aging our children, increasing their morbidity and mortality, making them more susceptible to disease. This is what the science is demonstrating.
This is not okay. So this is not, we all know those maps of zip codes where life expectancy is different. Like in my county, there's a 20-year difference in life expectancy based on where you live. And this is the science of why. So we actually know the why your environment, the air you breathe, the water you drink, the poverty rates. This is the why. This is incredible science, but we can't wait for this science. This is all preventable.
And so now, Dayna, what do you want people to do with that information?
I have a lot of suggestions.
You have the microphone, so please share them.
Great. So my first suggestion is that we continue to collaborate across sectors. I mean, what is so powerful is bringing together scientists and pediatricians and funders and policymakers to actually make great change. We have to have families in the room with us at all times. Some of the greatest lessons that I've learned are from my parents, being lockstep with them. And so now for all of my research, I really like acronyms. So we have what's called a FAB, which is the Family Accountability Board. And my families are holding me accountable to my science so that they are actually helping to direct the science with me. My other recommendation is, quite frankly, it's not enough just to say that we're anti-racist, right? It's not enough that as a mother of 3 Black boys, right, I am worried that if my son goes to pick up his sibling, he'll get shot in the head, right? So my huge recommendation is that we are pro-Black, right? Which is a much positive spin. Like, you can't just say I'm anti-racist. Like, are you pro-Black? And then that we invest with, to the people on the ground that might not be the bright, shiny stars, right? The bright, shiny people, but they're the ones that are actually making the difference. Like, go into community and invest in the community leaders in order to make the change.
Mona?
I agree. So I have a parent partner group, a group of parents that advise me. I also
But does it have as good an acronym?
No, but my kids do. We have I have a group of kids that advise, and they came up with their own name. They're the Flint Youth Justice League. So they're a badass group of kids, and we meet, and I stop talking, which is so hard because I love talking, and I just listen to these kids, and they tell us how we should do things. And they've become national leaders and environmental justice champions everywhere. And it's hard for us, especially as academics and many of our professions, to be quiet and to deliberately raise the voice of others. So all of our work is done in humble partnership with community. I have a director of community engagement. This poverty work that I talked about, it wasn't my idea. It came from our parents and our kids and their voices. So we have to make sure that there's, and kids especially are part of this conversation, because they are brilliant and they are inspiring. Yes, we don't need to wait for them to be leaders, but we need to make sure that we're listening to them and that they're at the table as much as possible.
I do wonder kind of what your experience over the last decade of being, part of kind of the group who raised awareness about the injustice, about the environmental injustice, the racial injustice, the injustice towards families, in Flint, and then trying to work on many different fronts simultaneously after that. Accountability, because accountability does matter. Structural changes in everything from kind of the way water was reaching communities to the way schools were being built and what was being taught, to what was happening kind of in the hospital or in your clinic. What lessons do you have from that last decade that you think could really help kind of inform this work going forward, for RX Flint particularly, or RX Kids, since I know you have a broader vision beyond Flint, but also just kind of this broader work of urgency that clearly we all feel?
I think one of the greatest lessons that I've learned from the ability to step out of my clinic exam room to very public spaces like this, to the halls of Congress, to the White House, to the in front of cameras, I have learned how important it is to be better communicators, how important it is for us to be better storytellers of this work. I had the privilege of being one of the co-chairs of the March for Science with Bill Nye, the science guy, which was so cool. But I did it to really kind of push academics and scientists and doctors out of the comfort of our ivory towers and our classrooms and our labs and our clinics where we go and we're cozy in there because it's safe, but really into these uncomfortable spaces, these spaces that we weren't ever trained to be in, to share the stories of our patients, to share the stories of why our science is important. This amazing science that she just published, like that needs to be an opinion piece in the New York Times, not just in this amazing journal, which is really good. It's really good to be published in peer-reviewed journals, but we need to make sure that we do a better job communicating these stories in really heartfelt ways. I had the privilege of testifying before Congress several times about the Infrastructure Act, which is the largest federal investment in water infrastructure. Because of Flint, we are replacing lead pipes across the country.
Including here in New York City.
Including here in New York City and all over. But every single time I talk to a policymaker, I start with because I can talk science and facts and pathophysiology, and they fall asleep. Like they literally fall asleep and they could care less, and you can see eyes roll back. But I started my last testimony before Congress holding a lead pipe that was excavated in Flint, and I shared the story of that lead pipe. And it was virtual because you can't bring a lead pipe to Congress because it's like a weapon. Anyways, so I knew the family. It was the Brown family who had migrated from Alabama to Flint as part of the Great Migration North. So fleeing the racism and the oppression of Jim Crow South, they came up to Flint for opportunity and prosperity and a chance at equality for themselves and their children, right? And for generations, they lived in this house with this pipe, and they drank water from this pipe, and they raised their family, in this home, and their great-grandson drank from this pipe and subsequently developed seizures and developmental issues. So I laid out the story of this family who we have failed for generations. Policies, our inaction, our racist policies has failed this family for generations. But then the pipe was in my hand. And then I shared that it was a story of hope, that we did this impossible thing because for so long, legislators would say to me, we can't dig up pipes. Are you crazy? That is so expensive. How are we going to go around this country and dig up pipes? And I would push back that there is a cost of our inaction. There is a cost. And that we did this here in Flint. And if we did this in Flint, we can do this around the country. So it is also a story of hope. So we need to be better storytellers. So after that testimony, I don't think they heard. Then I talked science and they fell asleep. But I think, I think we have to be able, and I think the only thing they took away from me was that story and me holding this pipe and sharing that this pipe was like a straw that millions of children were drinking, and that the straw has no safe level and it's a neurotoxin. So whatever we can do to practice being better communicators. I remember the first time I was a pediatric resident and they're like, we need somebody to go on TV to talk to the local news about back to school vaccines. And I'm like, I'll do it. And it was like, I said 100 times. It was the worst interview I did, but then you practice and you practice. So I think as much as we can ingrain storytelling and better communication into all of our work, we will do better at moving the policy needle.
You know, I do want to also open the floor for questions, but before then, Dayna, I have a similar, kind of query for you in that I know when you started the work on ACEs a number of years ago as well, there was lots of skepticism, so much cynicism that either, this wasn't worth doing because it was all kind of ephemeral and weren't you just supposed to like pick yourself up and get over it, whatever it was, or that it wasn't quantifiable. Even if the stressors were real, you wouldn't really be able to quantify them, or even if they were quantifiable, you wouldn't actually be able to have any correlate or causal relationship established. And clearly your science and also your storytelling has radically transformed the understanding of toxic stress, on kids and also, on adults. But what reflections do you have, for this group from that experience of kind of what you learned to really help push back against the cynicism and push back against the skepticism?
Biggest thing that I've learned is to be comfortable in discomfort, and that it is okay that I am often told that people feel like I'm threatening or that I need to slow down. And I have learned that I just continue to push forward, and that when I make people feel uncomfortable, it actually means that I am causing great change. When I first started doing research in this implementation science field, we were thinking about, this was 10 years ago, how do we ask questions around unmet basic needs? Is it feasible to ask questions about food insecurity, housing instability, discrimination within medical homes? Because there was no standard way or protocol to actually get at the true social drivers that were bringing folks into the healthcare system in the first place. And what I was told is, this isn't our job, people don't want to do this, families don't want to answer these questions. When the truth was, families want you to ask the questions because they want you to do something about it. It's the providers who felt too uncomfortable with their own privilege to be able to actually ask the questions. That pushing back continued when we really started the ACEs work. And now as we are honing in on health equity, I have found that there's a lot of theoretical talk around how we want to advance health equity. And it's theory. And when you actually say, what are you doing about it? Everybody just talks. And so most recently, I'm really excited, and I suppose this is like the first public announcement of a clinic that I'm launching in July called the Black Baby Equity Clinic that is focused on, you all are so wonderful, thank you. That is focused on racially concordant, trauma-informed, team-based care that actually makes mental health a primary care issue as opposed to a subspecialty referral concern, so that families don't have to have a diagnosis of depression or anxiety or historical trauma in order to see a therapist. But when you come to the primary care doctor, there's a therapist working with your primary care physician that can check in with you and say, how you doing today? We also, if you can believe it, we don't have lactation consultants in many of our primary care clinics. And so I will have a lactation consultant as well as a community health worker all working together. And there's pushback. There's always pushback. There's pushback that this should be available to all families. Yes, it should. However, it is our Black and brown families that have the highest disparities. There's pushback. You're promoting segregation. Actually, we're working in academic healthcare systems with a focus on families who are often the highest utilizers, where there's so much historical trauma. And so I have become a friend of pushback, and I welcome it because it actually means that we're making change in the world.
Questions for, yes, ma'am. Just shout and I can, just shout and I'll repeat your question.
Work, and we need to replicate it all around the country. And in that regard, And we know pediatricians are stressed and working so hard. I work with teachers. We're trying to integrate K through 12 climate education in schools. And one of the things we hear from them is they're afraid. They're not prepared. They don't have the knowledge. They don't have the experience to talk about it, to teach it. How do we reach more pediatricians and provide them with the same knowledge and expertise that you have in a bigger way so they can reach their patients and connect with them at this level?
There's big gaps, I think, in medical education, pediatric education. There's like 1 hour of environmental health education. There's a little bit of lead, there's a little bit of asthma, but there's not much. There's a lot to stuff in the curricula. But it's changing, and the change in that education is coming from the young people. It's coming from the students who are demanding to learn about racism as a public health issue. They're demanding to learn about environmental justice. They're demanding education on climate change. So it's out there. It's not as accessible and readily available. So I think the younger workforce gets it. It's the older workforce that needs work. Even when I went public with what happened in Flint with the lead exposure, I had older docs in my hospital say, but nobody's hospitalized that needs to be with seizures. I'm like, well, that's not what environmental health is. It's like you don't often see this. The consequence manifests years, if not decades later. That's the worst thing about environmental health. You can be exposed when you're a baby, but when you're like 30 or 40, you have problems, so there's a lot of education that needs to happen for the current workforce, but I have more faith in the upcoming workforce.
Dayna?
One of the really great things that came out of COVID is the collaborations that were forged between local health systems and schools. And so we were invited to participate on our local county's task force around COVID, but then they just sort of have morphed into these health system school task force that we talk about a lot of these issues. And so initially it was about safety protocols for COVID and vaccines, but now it's much more about how to just ensure the mental health and wellness. And so I would definitely recommend partnerships. In California, we have seen really dramatic effects on schools for climate change. And so now in California, we have wildfire seasons, which is where entire communities are evacuated, burned down. The air quality is awful. And sometimes schools are closed, but other times when kids are coming to schools, all the doors, all the windows have to be closed because of the climate, the air pollution. However, with COVID, you're then having a group of students indoors without ventilation. And so we did a lot of work with schools around how they can try to keep kids safe. Unfortunately, we had a lot of those same conversations during our recent atmospheric rivers and flooding that we had in California, that a lot of kids weren't able to get to school because of the rain, and then a lot of issues with leaking roofs and just flooding in general. And so these collaborations between the schools and the health system, and to actually have formal collaborations with MOUs so that the school always has a pediatrician on call. We also are doing that for our kids with special needs who had IEPs, individual education plans, that were really difficult to keep up with during COVID and distance learning. We have a pediatrician who specializes in kids with special needs, who is working with local resource centers in order to help kids with disabilities. And so I would recommend formalizing those partnerships so that there's always a pediatrician that's readily available to talk about a lot of the health issues and how climate is also wreaking havoc.
If I can just add one thing. So you mentioned that teachers are burned out and doctors are burned out. There's a lot of, concerns about the mental health of providers in this space. But I think doing some of this advocacy, world-changing work is joyful. So part of our program that we're launching, this ability to prescribe this anti-poverty pill, we're going to be measuring satisfaction of healthcare providers. And we think it's going to be an antidote to burnout. So I think that doing this other stuff that is outside of our usual work this is why we went into these professions. This is why we decided to become pediatricians. Why did we decide to become early childhood educators? We are in these service-driven professions. Our why is kids, right? right? We are all here because of kids, right? And that if you can reground yourself and do work that is bigger, impactful, I think it brings us joy.
Other questions? Yes, ma'am.
So thank you. Just to make a connection between the last conversation and this one, can you talk about the partnerships that you're involved in? Because I think the folks in this room are already read in, but there are, folks who hold this work with lots of different hats who touch these same communities. And in this spirit of not putting more burden on folks who already have a long list of to-dos, I think that there are municipalities that really are holders of this, departments of health, where folks find their hands tied. Like, you could be the greatest researcher on earth, but the Department of Health won't open the door or answer any local calls from community, then the problem doesn't change. So I'm just wondering about the level of interest and relationships at the health and safety, municipality, climate, all these climate plans that are coming out of every city, state, and government to access global funds and money for these issues. Where's the section on that? And is there collaboration coming to make sure there's an area for all of this where the rubber meets the road?
Yes, so the partnerships are key. Once again, we are right now convening environmental folks and early childhood folks. That's, atypical, but that needs to happen. Where there's educators and there's the healthcare folks, there's the government folks, there's philanthropy here. So all of these folks need to be at the table. I think another important partner that's been part of our work and this kind of multi-sector work has been journalists and media. We need more great stories. We need more long print stories. We need more journalists who understand these connections to bring more of these stories to light. So I would make sure that we always have them as a partner to make sure that folks in the lay audience are also very aware of these issues.
Dayna.
Money is also very powerful. And it's important to invest in those that often don't have the capital and the resources. And so when grant making happens, I love my academic institution, but give the money to the community partner, right? And let the community partner then douse out the money to the ivory towers, shift those power dynamics and build infrastructure and support in the community in order to really start the partnerships, because otherwise it places such heavy burden. If a small community organization has to contract with a large academic university, it can take a year just to get the contract executed. But if you put the money and the power in the community, then it's so much easier to make that money move around.
Well, and I think Dayna, that also relates to the need to broaden the conversation around decolonizing aid, which often is about kind of global north to global south, but very much has or should have manifestation in this country too. Other questions? Yes, ma'am, in the back in the peach.
Thank you. This has been a terrific panel. Thank you so much. I know there's later a conversation about federal and national. I'm wondering, given that you're local, what's a big sort of macro change or something that would help you in your work, that would help you in your communities? What would you like to see change? Yeah, I'm with 0 to 3. Thanks.
One of the most heart-wrenching aspects around climate change in young children is acknowledging the science that caregiver stress is one of the biggest influences on child outcomes. And so with low resource communities and communities of color, it is that resiliency piece that always outweighs, right, the stress. And if we can actually build skills and capacities for resiliency within the caregivers, children do better. And on a federal level, we need to help to resolve and resource communities with better food and better housing and better quality of education, because then when the disaster hits, families are on more solid ground and can rebound faster. And so that would be my wish, right? That we can actually address these unmet basic needs, so that when we are experiencing climate change, we can actually have resilient communities, because it is always the Black and brown and low-income people that fare worse, because we start out in an unequal place in terms of basic needs and resources.
So I've thought about this a lot in terms of what I would love for kids at 0 to 3 at the federal level. And we need a voice for children at the federal level. I want a secretary for children. Maybe we'll talk to the secretary about that. I mean, there's some kid stuff in HHS, and there's some in EPA, and some in education, but like there needs to be a voice for children, or at least a White House office for children. We need every policy needs child impact statements. We need the lens of children from the life course in every bridge we build, every policy that we pass. Not just what happens in the next 5 years, but how does this impact kids for the life course? So that is my big pie in the sky dream at the federal level. But obviously, like an investment, like we know what kids need. They need good food. They need to meet, families need to meet their basic needs. We need stronger WIC. We need SNAP. We need to strengthen all of our safety net programs. We need universal child allowances. We need healthcare untied to employment. We need universal child. These things are standards in other countries, and their kids flourish a lot better than our kids. So we don't have to come up with like brand new crazy ideas. Those ideas are out there. We need to implement them here.
I nominate you, Mona.
Thank you.
Well,
I accept.
And if I may, also, some of those ideas we had over the last few years, and we didn't
Build Back Better, yeah.
Yeah, and we didn't seem to learn the lessons that I wish we had. I am profoundly grateful and humbled always to be with Mona and Dayna, and I always learn so much from them. And I hope that they each are swarmed, bluntly,
By funders.
by all of you, by people who, there were questions about partnership. Please reach out to them if you want to partner. If you also want to start a Black birth equity clinic in your institution or your neighborhood, if you want to go volunteer with what they're doing, if you want to fund what they're doing, if you want to help elevate their profile, if you want to nominate either of them to be hopefully the first Secretary of Children in our country, but truly, this is now what I'm asking all of you. Please, for our previous panelists and for these two panelists, please go up to them, share your ideas, share your thoughts, share your resources, share your attention, share your time, and hopefully share your commitment to supporting their work and all of our work for all of our children to have healthier futures. Thank you all so much.
Thank you so much.
Mona and Dayna.
Thank you.